Okay, welcome everybody. It's so great that you already so many of you have joined us for the introduction. We know that the first session of today is going to be Gareth, who's already with us, who's going to talk about international and wider context of care development, and also show us a bit of, or talk about a bit of a history of what's been happening earlier on in the days. One of the things which is happening during all 3 days is a group called Dance Syndrome, whose members and dance leaders will take us through session on each of the days and talk about how they do things, really, how they look at inclusive dancing, which is focusing on everybody's abilities rather than whether people can or cannot do things. After Gareth today, Adrian Ashton will join us, and he will be talking about federative ways of working. He's been working alongside us for the last few months, and he's got a great introduction, really. It feels a bit of a start of the journey for us to sort of look at how we can work with others to scale up what we do, not in a way of growing bigger and bigger, but joining with others to be able to have wider impact and to be able to sort of support wider communities. And later in the afternoon, John Roberts from Northwest Care Co-ops will have testimonies to share from their members who talk about living lives well, really, rather than giving or receiving care, which is another lens, and which they have been doing for a few years now, and they've been growing fairly recently as well. So it'll be really interesting to hear. And if you're able to join us in the afternoon at about 4, Adrian will be leading a session on networking so that we can maybe talk a bit more with each other in smaller groups and look at what sort of skills we can offer to each other, and what are the ways of working we can take forward, and what would be what are the things we can really exchange, and so that we can learn a bit more about one another. There's going to be rooms full of people with variety of skills. There's going to be different interests in the room. So I think it'll be really interesting to sort of know and get to know more, get to know each other a bit more. Today feels a bit more laid back time-wise. We've got a bit of a sort of timed breaks in between the sessions. Friday is starting earlier, so I would recommend that you get a good night's sleep for that. And we also have, because there are a lot of people who are joining us, we have shorter breaks, and the program is just really packed with really exciting speakers. So Power to Change, who've been funding our learning program, are going to join us, and Susie Finlayson, who's one of their managers, will talk about Power to Change's take on and support they've been offering within social care sector. Change agents then, who have been working with us as well, are going to join us later on, and they'll talk about participation and co-production, and we'll have Mervyn Eastman and Cheryl Barrett from the group joining us to do that. Cheryl will then stay on, and we have Rose Marley, who's the Chief Exec of Co-ops UK, joining us, and they will talk about together about Co-ops UK sort of lens and aspirations around opportunities and challenges of cooperative care. After that, we'll have the dancers joining us again, and in the afternoon we'll have 2 sessions, one with Emma Back from Equal Care Co-op, who will be looking at digital in social care. They have been doing some great work and have some great progress around setting up Equal Care Co-op, and will be able to give us an update and talk about Digital Care Commons, as she's called the session. And then Anna Severite from Social Care Future will join us for the end of the day, and she'll share updates about Social Care Future's inquiry. They have been looking into what actually social care means to people, and how could it look going forward, and what we can all do to be part of that and support their great work and become part of the movement altogether. And then Saturday feels like mostly Cooperative Care Con Valley Day, where we'll be starting with Sue and Jean, who are our board members, who will give us an update on how our work in the community in Coal Valley has been going since we've been out and about for about 3 months now. and have been supporting people in the community. Then we'll have Graham and others as well to talk about the toolkit and the learning project overview. So the session today and the sessions over the 3 days are part of our learning project, and we've been working on bringing resources together and bringing people together to be able to share learning we've gleaned and to sort of join that right across the sector, really. And then we'll close with Sian Lockwood from Community Catalysts, who will join the session together with Down syndrome again, because Down syndrome have been one of the micro enterprises Community Catalysts have helped to set up. So they've agreed to do the session together. So we'll basically finish off the 3 days with a dance off, and then briefly close in the early afternoon on Saturday. So we're hoping that each of you and all of us will be able to choose something there. It looks very exciting. We're hoping to offer a mixture of both theoretical and sort of wider thinking around some of the care cooperative ideas and some of the ways of working, but most importantly, making sure that where it's possible to hear the voices of people who are the most important and absolutely central to care, who are the people who receive care and who are the people who give care. And while we at Valley Care can't do that sort of right now because we're very small and drawing on people's time and skills and efforts can be sort of tricky, we're hoping that we've managed to pull a lot of people in who are going to be able to do that alongside us. Okay, that was a lot longer than I thought, actually. Thank you very much. So how about somebody else from our team offering a bit more of a take, and then we're nearly ready to start with Gareth's session at 10 o'clock.
I could say a few words if you want. Yeah. Yeah. Good morning. Welcome, everyone. It's great to see so many people here. I'm really looking forward to what's coming up over the next few days. I think it's going to be really interesting. There's loads of stuff that I don't know much about, which I'm keen to learn about. Which we've got Gareth coming up next, talking about some interesting stuff on that front. But what I just wanted to really say that I'm particularly looking forward to conversation. Really, I think it's we can all get a bit swamped, can't we, with lots of sort of presentations and slides and all that sort of stuff, and listening to people talk, which is all well and good, and I'm all up for that. But it's actually the sort of conversation and what happens there, I think, is probably the richest bit. So do pipe up if you've got questions or points you want to make. We're very, very keen to get as much of that flowing as we can over the next few days. That's all I'd say, really. Thanks, Veronica.
I could say a couple of things. I'm Sue Richards. I'm the nominated individual with the Colne Valley Cooperative, and I think what we're trying to do is really hard. Hadn't realised how hard. It's tough sometimes, and sometimes you feel a bit like we're on our own with this, and are they just all silly ideas, and are we too aspirational? And it's a bit of a fix for me to join things like this, because you realise there's a movement behind it all that's got some learning for us. We can offer some learning, and that if we keep on sharing things, we can have the power to actually change the experience of people who need support to live their lives well and not just feel like recipients of services. And we can make our staff feel valued and included in the way our cooperative develops. And I think, and I hope, we are starting to reap some of that now, even though we are small. We are learning how to do that better, and it gives me some hope.
Thanks, Sue. Brilliant.
Yeah, I wonder whether I wonder whether we hand over to Gareth then. We've got a couple of minutes to go, but I don't think that does stop us. So unless there's anybody else who'd like to sort of feed in anything before we start, let's give the floor to Gareth.
Mark, you've got your hand up.
Hi. Good morning to everybody. We haven't met before. My name's Mark Tilston, as the label says. And I'm part of a new initiative in Ealing, the Ealing Care Cooperative. We just recently become registered with Financial Conduct Authority, and we're looking for funding, and our approach has been to set up a home care service in competition with all of those others out there that are doing it sadly for profit. And we as a cooperative movement and everybody present here, I'm sure, want to see less of that and more of what we're trying to achieve. And I put my hand up because I'm interested to learn how everybody is wishing to be involved with this sort of setup here that's been organised, and whether everybody else in their areas are actually providing a cooperative home care type service or something else as a service to the public, rather than being part of a group that wants to actually just improve the service. So, Veronica, Graham, can perhaps everybody just say what their organisation is and what they're doing? I think that would be helpful. Thank you.
Yeah, sorry, Mark, you were breaking up a little bit at the beginning. So we've
Sorry, was there a problem with my transmission? Because I haven't had a response.
Yeah, no, I think that was okay, Mark. We got the gist. Your audio signal was very clear, but I think we understood briefly. Yeah, so I think what Mark was saying that is maybe a very brief, sort of quick once around the room, so that everyone can just say what their involvement is, and then we can kick off with Gareth. Does that make sense?
How about we use a chat for that? Because then people can also keep it and you'll be able to download the chat with the names. So if everybody, yeah, how about if people are able to put maybe the name and the organization name in the chat, and then Mark will be able to sort of get it from there as well.
Yeah, that's great. And please include links and email addresses and things like that. That would be useful. That's really, really helpful. Okay, so let's go to Gareth then, without further ado. So over to you, Gareth, if you're ready to roll.
Yes, thank you. Hey, good to see everybody. Can people see that okay? Yeah, can people hear me and can see that okay?
Yeah, that's fine, Gareth. Thank you. Yeah, wonderful.
Okay. Look, thanks ever so much for inviting me to speak today. I've sort of sat alongside Cooperative Care Colne Valley with the webinars and other learning things, and I think it's been great. This is what I'm going to chat about today, and hopefully there will be please input into the chat, and there'll be time afterwards for a discussion. So I'm going back to the Cooperative Care Forum, which worked between sort of 2015, 2018, and it's great to see some colleagues here today from the Care Forum. I'm going to talk a little bit about what we learned about international cooperative care, how cooperative care has developed in the UK, particularly from the worker model to the multi-stakeholder model. There's a few housing and care developments that I want to highlight, and then lastly, just very briefly, to touch on developments in care. So so the Cooperative Care Forum was formed in 2015, and I think that the stimuli were this disturbing developments in health and care services at the time. We all know what they were: Winterbourne View, Southern Cross. The knowledge that large hierarchical corporates and to some degree local authorities were not delivering high quality care. And the third stimuli, I think, was a Cooperatives UK report, which Pat Connaughty and others wrote, which examined the UK context and also the international context. So I think the forum was interesting because we worked for 3 years, and we wanted to focus on cooperative approaches. So while the social cooperative model from Italy was extremely interesting, we wanted to focus on cooperative approaches to care, a way for those who are being cared for and those who are caring to come together and meet their common needs. So we focused on those who were cooperating for the purpose of care, so not the legal construct, and we tried to sort of define the sort of cooperative approaches, and this was, I think we thought that this was about orienting organizational purpose towards meeting the needs of users, communities, practitioners, empowering users, family, communities, practitioners, and involving all of those constituencies in co-creating the organization. So at the time, and I mean, it's interesting to posit whether there's been any movement here. At the time, the forum was established against a sort of backdrop of an aging society, fiscal constraint, privatization, commodification of care, and business failures. I think that we were keen to explore different models. There's also cultural issues, which I think we came across, which, you know, that this whole thing about public services, having things done to them rather than by them and with them. And care, I think particularly healthcare has got this paternalistic tendency of, you know, people with information and people without information. And I mean, there was an overwhelming, and there still is an overwhelming sense that actually we want to promote a different deal. So the forum was particularly interested in approaches to care that are sort of rooted in communities and encouraging relationships between people, neighbours, family, paid carers, volunteers. And I think we believe that mutual self-help, solidarity, the fairness inherent in the cooperative approach was highly relevant. And we thought that, you know, the advantages might include enabling citizens and qualified carers to work collaboratively together. Of course, you know, this is I think the very essence of cooperative care, Colne Valley and other embryonic care organisations. Engage those accessing care and providing it informally and professionally, and recasting the role of care workers who have historically been, you know, poorly treated and poorly regarded. So we worked for 3 years with key speakers, and we had meetings, and we also undertook some primary research, which I think is interesting to reflect back on. So this was a relatively small piece of research, but I think it's important in what we found, which we were keen to capture we were keen to sort of to chart current activity as far as we could, to capture the challenges that participants encountered in developing community care, and also to identify the sort of kind of interventions that helped move these things along. So we charted what was the overall experience of users and staff, what forms of non-financial support, and what forms of community leadership was relevant. So one of the case studies highlighted the benefits it saw from combining sort of personalisation with social activity and community empowerment, so that the individuals could have more control over their activity without being sort of isolated consumers. And I think all of the case studies felt the challenges of working through cooperative approaches, getting the skills balance right on community and user-led management committees. One of them mentioned the issues with volunteers being inappropriately perceived by commissioners only as an untapped cost-saving resource rather than part of the organisation's DNA. In terms of what people thought was useful, business development advice, particularly with a cooperative flavour, was very useful. Community development, absolutely vital. Assistance from the local authority in terms of managing bureaucracy and organising invoicing for very small organisations. Organising premises. So these were important things in terms of facilitating small community organisations. We organised an event in Kent, actually, which was interesting. The people in receipt of care, providers and support workers, and commissioners. And the people in receipt of care, they emphasised relationships based on trust, much more than transactional, enabling people to live good lives, and the fact that they were often not listened to by institutions. Providers said they were undervalued, they lacked decent training, and often CCCV regulations prevented them from innovating. So it's good to see Kelly Hall here today, because we had contact with Kelly during the Cooperative Care Forum period, particularly around whether micro enterprises outperformed large care providers. And I think that her research, which I can't begin to detail, explored different types of innovation, actually, what, how, and who, and it was felt that micro enterprises were particularly good at the how and the who innovations. Okay. So in terms of international cooperative care, I think we all learned huge amounts about what was going on in other countries, and I'll just briefly go through these. The Italian social co-ops, they grew hugely during the 1980s, and they were given, of course, a legal framework in 1991. And I think recent figures show that there are around 15,000 social co-ops employing well over 300,000 people. So Italy has sort of spearheaded a sort of transformational development in the labour market in care. And I think that for me, the stimuli were clearly the fact that the various co-op leagues supported this effort, the legislation that they managed to get in, the social co-op law. There were various incentives like lower corporation tax and VAT rates. There were incentives such as the exemptions from national insurance for the so-called the user workers. So that was that. There was exponential growth in Italy over that period, which is, and certainly many of them are still trading. In Quebec, Quebec was inspired, in fact, I think, by the success of the Italian model, and they created a development and networking organisation called the Chantier de l'Économie Sociale. And that's interesting, I think, because its objectives, they bring together stakeholders, they promote the social economy, they create the conditions and tools that co-ops need to thrive, and they form alliances across the piece. And that's been successful. There were some over 11,000 co-ops, and they've particularly been, because of the nature of Quebec, they've been particularly good at branching out into rural areas. The Han groups, Hanskai. So Japan has a significant health and welfare co-op federation, which runs hospitals, primary care centres, nursing facilities, dental facilities as co-ops. But what they felt was missing in Japan was prevention, and the unit is the Han group. So a Han group is the basic unit. So it consists of a number of members at the neighbourhood level who are supported by professionals and who enable people to maintain good health. So people learn about diseases and the treatments, and they also engage in activities such as exercise and social activities. And that, I mean, it feels to me like, you know, it fits quite neatly with what is currently happening, certainly with Cooperative Care Common Valley, that people get together in their neighbourhood and actively engage in programs while receiving help from professionals. So the last one on this list is Bertsorg, which is not a co-op actually, but it's I think we would probably describe it as a social enterprise. And Bertsorg in Dutch means neighborhood care, and its defining characteristics is its holistic approach to care. So nurses and nursing assistants working in small teams. And the other central feature of Bertsorg is that it's flat. It's a flat organizational structure. So you've got local teams supported by clinical staff and very, very few people in central office. It reminds me slightly of Timpson's, which is an upside down organization where Timpson's is absolutely committed to serving the shops where people who've been in prison work. So that scaled very, very quickly across Holland, and we have there was a pilot in Suffolk, I think, Bertsorg, but now we have Bertsorg UK, and it's building from the bottom up. And so perhaps there are some lessons for us here in terms of expanding scalability and replication. Okay. I think it's interesting that in the UK, the emphasis until relatively recently has been on worker co-ops. And I think what is changing is the emphasis on involving other stakeholders, which for me is enthusing. I'll just briefly go through these examples. Foster care co-op started in 1999. Laurie Gregory, actually, who was a member of the Co-operative Care Forum, was one of the founders, and the stimuli for that was, again, to have a cooperative version of what was becoming almost entirely private sector, where the private sector were poaching public sector foster carers, and it has expanded. It's operating. It operates nationally, as far as I'm aware. It's got offices in Cardiff, Bristol, Glasgow, London, and I think what is fascinating about the foster care co-op is that its placement stability is 9 times above the national average. So employees are members, foster carers, because of the regulations, can only be associate members. Be caring. Those of us who are of a certain age will remember Sunderland Home Care Associates, which Margaret Elliott started, which then became Care and Share Associates, and they sort of went for a sort of a franchise model, and that has now, I think, that's been absorbed into Be Caring, which is described as employee-owned. It's not a worker co-op, but it is employee-owned. And it's largely north of England. Highland Home Carers, that's a fairly significant organisation in Scotland, which a major provider of care in Scotland, with some 500 staff and 7 million turnover, and that is also employee owned. So there has been a has been a there's been a worker-owned or employee-owned focus, I think, to cooperative care, and then there are some multi-stakeholder, what I think I would call multi-stakeholder community health mutuals, and the one that I know best is Care Plus, which is I mean a very significant organisation, about again 700 staff and 23 million turnover, which provides all kinds of care across North Lincolnshire. And then most recently, we've had the development of what I would call, which I suppose goes back to the Cooperative Care Forum, you know, the multi-stakeholder co-ops, Equal Care and Cooperative Care Colne Valley. And of course they're running, I'm not going to say anything about those models because they're running sessions themselves. So just before we get on to developments, although I'd come across Wiesp in Holland, and I'm aware of OUCH, which is older women's co-housing in London. I only came across these the top three, Bonnie Downs, Homes of Mind, Ginger last week in a seminar run by Community-Led Housing London. And I mean, I think it's just interesting to posit the linkages between community-led housing, which is an expanding movement, and cooperative care. So Bonnie Downs is both Bonnie Downs and Homes in Mind are embryonic. And they're both, Bonnie Downs is attempting to create a building with some intentional housing community above a community resource for vulnerable people. Homes in Mind is being fashioned by Mind, indeed. So it's about providing housing and care for people with mental health issues. I was intrigued, I have to say, by Ginger Giraffe, because this is a co-housing community comprised of people who have health and social care needs, people with a disability, as well as those who can provide the necessary support, such as carers and students. So they are learning as they move through their studies, and they describe themselves unequivocally as a co-op. So Holgaway Village is a village. It's a village with for people who are experiencing dementia, and I think it's fascinating because the site has a 1950s feel, which is the decade when most of the residents were children or adolescents, and 6 or 7 residents occupy houses, 2-story houses alongside 1 or 2 carers, and of course their activities are co-organised for residents. There's almost 20 clubs. So going back to living a good life, you know, for people with dementia, I thought that Holgaway Village was a really interesting example. So almost at the end. I think organisations with an interest in the future of social care are multiple, aren't they? So you've got the local government association, Directors of Adult Social Services, BMA, National Care Forum, Skills for Care, Independent Age, and they're stressing, I think many of them are stressing that the singular focus on funding is insufficient. I mean, we're waiting for the Health and Social Care Act, clearly, but the comprehensive reform of the entire system is required. And that's certainly, I've cited the Nuffield Trust there because I think they're not the only people in the market, but they're trusted. I think they're trusted. And certainly Nuffield cites problems such as the downward pressure on fees over the last decade, commissioners with tight budgets, losing experienced staff, a lack of reliable data on providers, and this sort of short-termist approach to individual care packages. Also, of course, we've got opaque ownership and complexity of business models, which in what is actually a very complex market. If you look at the data, which is March 21 in that report, the Nuffield Trust report, there are 10,000 locations of domiciliary care, 2,000 locations of supported living, 540 of extra care, and 130 of shared lives plus. I think what is interesting is that these smaller providers get good reviews, actually. And what is the opportunity for cooperative care to insert itself into this system as it currently is at the moment? The Shared Lives Plus is, they describe themselves as fostering for adults, which I think is quite neat. But Nuffield is saying actually, well, you know, come on, this isn't expanding. This type of service is expanding. So I suppose my question is, what opportunities are there for cooperative care to move to expand the Colne Valley and the equal care models? Actually, I think we say check at the end, don't we, when we're finished? And I'm very happy. I mean, as Graham said, I think the important bit of this is networking and discussion and learning from others. So I hope I've given enough time for that.
That's brilliant, Gareth. Thank you very much. Have we got a bit of time for questions, Veronica, and conversation now? Yeah, I don't know if anyone's got
absolutely
specific points they'd like to raise with Gareth. Well, that was quite a lot of ground covered there.
I'll stop sharing, okay, so that
Great, thanks for that.
There wasn't anything specific in the chat people have asked. It's been really great exchange of thoughts and links as well. So if anybody's got anything they want to ask, yeah, or Cliff, I can see Cliff straight away, unless anybody else. Yeah, do you want to go?
Yeah, thanks, Veronica. Thanks, Gareth. Really interesting to remind ourselves of what we've been doing the last few years. Just a couple of things that, just to add to what you said, on the multi-stakeholder front, I don't think you mentioned it, but and Colne Valley, they've had a presentation from them, but Cartrefi Cymru are a substantial provider of supported living in Wales, across Wales. They were set up as they are a company limited by guarantee, which is a charity, but they converted to a cooperative structure and have both employee members, user members, although they don't call them that, and community members who are families, friends, and volunteers. And they've got quite a kind of sophisticated structure to make sure that all those voices are heard within the governance. One other thing that we personally, because I was on the Care Forum with Gareth and James and one or two others, and one of the things that was I was particularly interested in, which ended up going nowhere, but I still think it's an important idea, was the idea of a cooperative of people that held personal budgets or were entitled to direct payments under health and social care. And the idea of a cooperative of budget holders was very attractive, and any local authority or other organizations we talked to said, yes, this is definitely something we should be looking at because of the efficiencies of pooling budgets and getting people collaborating together, using their money collectively. But the complexity of it meant that, in spite of a lot of different initiatives, both within amongst foundation trusts, care providers, local authorities, CCGs, it was impossible to get a project up and running to develop the idea. But I still think it's something. I mean, unfortunately, the guy we worked with, who was an expert in personal budgets, is now given up on the idea because we got nowhere. But the principle behind it, I think, is good. And then just the third thing to mention, which we didn't do a lot in the Care Forum, but there are a lot of healthcare connections, international healthcare connections through the ICA, and I think it was in 2013 I went to the Quebec, the big summit, cooperative summit, and went to all the health ones then, and met the people from Australia, South America, Japan, Canada, and there is a significant body of people. Well, as Gareth mentioned, the Hans Kai initiative in Japan, the Canadians have picked that up because there was a view that Hans Kai worked for Japanese people but wouldn't work with other cultures, and the Canadians have disproved that and think it's a brilliant approach. The South Americans are doing all sorts of different things that we're not really following from here, it's probably a link that we ought to be more. We ought to follow up more, because there are undoubtedly initiatives going on that we could learn from and share with. That was all from me.
Thank you. I think we've had Ian wanted to go next just after. Cliff, do you want to go?
Yeah, just following up from what Cliff said. Has anybody talked to Mick Taylor, who ran a pilot of the aggregated personal budgets? And although he's retired, he's still got his models and thinking and reports available if anybody's interested. I think he's based in Norwich. But he did his work ages ago in the 90s when personal care budgets first came out, and everybody was dead keen on it, but it never got anywhere. But there was an NHS pilot, so it's been evaluated too in London somewhere. I'm very sceptical about this notion of a care market. I can't conceive of social care being a market. It just makes me feel a little bit ill. And having seen the social enterprise start off as a whole load of very keen nurses taking forward all sorts of initiatives and turn into now budget maximizing business is really disheartening. So this market thing, I'm not sure it's such a great idea.
Should I just respond to some of that? Yeah, I mean, Ian, you're right to mention Mick, who I think is retired now, isn't he? I think he's retired in Norwich, and you know, Mick and Sippy did do some great work around care co-ops. I mean, I think like Cliff, I don't think that personal budget co-op idea. I mean, if anyone knows of one or two, then that would be extremely useful. But I'm not aware of co-ops that use that model extensively. I mean, it's also worth saying that the personal carers, as I understand it, that the numbers of personal carers that are employed via personal budgets are running to tens of thousands, and they're not CQC regulated, are they? That's my understanding.
I think that's correct. Yeah, I'd be interested to continue this investigation. I don't quite understand. Sue, you put something in the chat about this. What was it that you were trying to do and getting frustrated by there on this issue?
Well, we tried to we tried with parents of children with a learning disability leaving school, which seemed like a great place to start, because they were all people who'd been to school together, likely to develop relationships as parents and as young people themselves. And so tried really hard to get some interest in them pooling their budgets to sort of micro commission support. I really worry about, I worry enormously about personal budgets and purchasing a service off one person. I think the idea is great, but what I have found is, particularly in learning disability, is that, as you say, it's not regulated, which is not something to take lightly, but you can get over that. For me, it's really hard being a person who spends all your time with one person, and it's very hard for that person to spend all their time with one carer. So, you know, it's almost like we've talked about perpetual tourism in the learning disability world, where your carer thinks of something for you to do that day, and mum and dad want you out of the house because actually you're in the house all the time, and it can be quite a burdensome thing for everyone. And I always felt that if you could get a group of people together who could form, or who had formed and could continue those friendships and relationships, it was much better for carers, and it was much better for the people being supported to be part of a community, rather than this carrying the burden of a personal assistant around with you on your shoulder all the time, which is sometimes what it felt like. I remember sitting in a restaurant once, and a carer sat with a profoundly disabled young woman, took her coat off, ordered her food, fed her, wiped her chin, put her coat back on, and never spoke to her once. And that can't be a good service at all. So I'm not saying that everyone's like that. There's some great personal care, personal assistants, but I think it can be a frustrating and difficult occupation.
I can see Lionel. Yeah, do you want to go next?
Hi there. Yeah, I'm in Ealing with the Ealing fledgling Ealing Care Co-op. My wife's had a personal budget for 20 years or so, and although she's now with Continuing Healthcare, and she's employed her own PAs for a long time. And I think it's really interesting to think of the idea of people with personal budgets coming together to form a co-op. But it's incredibly hard work, as she likens it when she tries to explain what she does. It's like running her own business with all the work that's involved, and you know, she manages it, and the trade-off, and I think the benefit that people with personal budgets get is because of the choice and control and the sense of independence in how they want to lead their lives. But there are consequences, both administering it and the HR, the relationship that you have with your employee is lots of pros and cons in managing that. And she's very as active as she can be in trying to get her own support and counselling. You know, when you have a disagreement with a PA who's working for you all the time, it can be really difficult in how to handle that, because you have issues of dependence and but a sense of your own freedom. And it strikes me that I'm not sure that people have that capacity to come together to organise as a co-op just because they all share the fact that they're on a personal budget. But it does seem to me that the cooperative ethos, if an area is developing a co-op, that people with personal budgets, as John in Chester, John Roberts, has obviously he's put in the chat, you know, many of his people are on personal budgets, and I think that it's really an ideal. There are many advantages I can think of that the co-op ethos would work for people with personal budgets if they can see get more of the benefits without the overhead of needing to run the whole thing themselves in a more distributed way. So I can sort of understand why it never took off when it was looked at previously, but I do think that you know, there are some ways that it could work together, people with personal budgets and existing co-ops.
Thanks, Lionel. Can someone explain to me the difference between a direct payment and a personal budget? Is there a substantive difference there?
So the legislation and guidance says that everyone should have a personal, and this is another frustration, everyone who gets an allocation of funding through social care should have a personal budget. Some people can take that as a direct payment, and some people's personal budget is organised by the local authority. What I think most of us will find is that when you get a direct payment, you know how much dosh you're going to get. When you get a personal budget, it often comes in the shape of 4 calls a day, and you can't, and it's difficult to get the local authority to organise something more creative when they're managing your money. There should, in reality, there should be no difference. You should be able to say, I'd like you to manage it, but this is you know, how much have I got? I'd like you to manage it, and this is the sort of thing I would want. In reality, it often comes down to what I call the 4 calls a day culture, which is something we all struggle with.
Okay, thanks for that.
Yeah, thank you for clarifying. I've always used those terms interchangeably, and I appreciate the understanding of the difference.
Yeah. Anybody else? Cliff, do you want to come back again?
Yeah, I don't want to hog the floor if others want to speak. I've just put in the chat because they attended one of the webinars, I think, Graham. There are some in Australia, some families who had adult children with learning disabilities who were having a terrible time with their youngsters being sent miles from where they lived, and basically not good institutional arrangements. They decided to set up their own arrangements where they converted a house. They housed all the youngsters together, and the families ran it with support. And so the parents basically took control instead of being completely excluded from it. And it coincided with a change of the funding arrangements, from just simply being state funded to being insurance backed. And it was the change of funding which enabled this big development to take place. And the link I've given you is to the organization which now is helping to set up lots of these organizations. And it seemed to me that Lionel, I take all the points that you make. Yes, the complexity of doing it all, but sharing the complexity through a cooperative and actually being able and seeing this on a larger scale. I think doing it as a one-off would be very difficult, and we always saw it as potentially a kind of movement. If you could have a number of these organizations, you would want them CQC regulated, and we had conversations with CQC who were also very interested in the concept. But it's the change of funding which I think creates the opportunity for this. And the problem in healthcare, of course, is that health and social care is that up to a point it's free. At the point of delivery, subject to all sorts of wrinkles, and therefore what's at the heart of a cooperative relationship, which is an economic one, doesn't happen in health, because you can go to the hospital or the doctor. As soon as you've got personal budgets, you've got a consumer with money who is capable of that economic relationship is capable of being captured within a cooperative. And that's, to me, that was the sort of light bulb moment for me when I learned about direct payments / personal budgets. That change to empower the citizen, could we use that from a cooperative perspective to build into care what's always been missing in care, which is the economic relationship?
It's Phil speaking, Graham. Can you hear me?
Yes, Philip, yeah, we can hear you.
Yeah.
Oh, thank you very much indeed. It's nice to see everybody. I'd just like to say that social care, whether it be residential or domiciliary care, personal care, it's just a highly fragmented market. But what you've done in Kirklees is superb with the Colne Valley Care Cooperative. What I'm suggesting is that cooperatives or local authorities could establish an advisor, a cooperative advisor, who could advise individuals and groups of individuals, excuse me, how to form a cooperative, how to administer personal budgets or direct payments, what they're entitled to, what they're not entitled to, and try and get rid of this ridiculous market in domiciliary care and treat people as human beings and not just consumers. Because a lot of elderly people have got generous pensions now. I get a generous pension. Heaven knows what's going to happen to me when I need domiciliary care, but it doesn't matter until it happens to you. That's the essential, in my view. It doesn't matter until it happens to you. And what you've done in the Colne Valley is marvellous. Thank you.
Thanks for that.
Thank you, Philip. Yeah. Does anyone want to come back to that, or can we have James, who's been patiently waiting? Yeah, James, do you want to go?
Yeah, just to say that I've stuck in the chat a Dropbox link to a write-up of what I think was the research that Mick Taylor was involved in the late noughties. I think it's a write-up of that research, if that's what people were referring to, which involved the creation of a multi-stakeholder cooperative in Croydon, which the last time I checked is still up and going. That research was actually on our website at one point, but I think since we had a new website, it's not. But the link that's there is linked to the file that's in our Dropbox, so hopefully it'll work. If not, I can circulate the PDF to people afterwards. It is a good bit of research, and I think the work that Mick Taylor did all those years ago now just looked like it was really useful. It just happened to come at the end of Labour's time in government, and the government afterwards obviously wasn't so interested in its findings. But it's there in the chat.
Thanks, James. With your sort of policy head on, have you got any inkling as to what might be coming down the track in terms of changes in policy on social care?
No more than anybody else. I mean, there's the lines in the Queen's speech which seem very familiar to lines that have come in previous speeches on the steps of Downing Street and previous secretaries of state, etc. No, sorry.
I thought I might ask.
Yeah, do you want to go, Sue? Thank you.
I think it's probably worth mentioning the anomalies in the way that money is allocated. I mean, you can't get away from you can't go into this discussion without talking about how difficult it is to make it all work with the current funding arrangements, which is why sometimes the pooling of budgets is attractive. The local authority, because they've strapped for cash, as I know to my cost, the local authority pays a different amount. If you have a direct payment, you get something like £15 an hour. Ooh. The local authority know that they can't buy services for £15 an hour, so they will give £19.50 an hour if they organise your budget for you. Self-funders are mostly charged around £22, £23 an hour. So there's got to be some anomalies and potential unfairness in that you know, I don't know what the answer is, but it certainly raises questions for me.
What are the assumptions that go behind those sort of price differentials, Sue?
The local authority have an obligation to give a personal budget that is affordable, that you can buy services, and so they reckon that I mean, the ridiculousness. I was talking to a cleaner yesterday who charges £15 an hour. The personal assistants mostly charge around £11 an hour, and that's what we pay our staff, and that can't be right, can it? I think that the local authorities have got to that point through experience of local authorities desperately want to give direct payments. They're measured against how many direct payments they give. But as was pointed out by Lionel, I think it's a very onerous thing to do your direct payment. You employ somebody when they're sick. What do you do if they want holidays? What do you do? Again, he said the relationship. So I think that there's not as many direct payments as the local authority would like. And then care providers cannot make it work on the allocation of budget that I think there's something in the news this morning about it, actually, on the allocation of budget that the local authority will give to buy care. Hence, you then get block contracts, and in block contracts, you take the person out of it completely, I think, because what you basically get is, this is a provider that works in your area, take it or take a direct payment. So, you know, the actual choice and control doesn't exist when you just have a personal budget and not a direct payment.
Right. That's really interesting.
Thank you. Kelly, do you want to go next? Oh, we need it.
Yeah, so unless anyone wants to respond to Sue's point, so I'm kind of changing track slightly. Okay, so I suppose I was just going to kind of ask a more general question, potentially of Gareth or others, just around co-ops and how much support you feel there is for co-ops at the moment and going forward, just I suppose nationally and kind of at local levels. And I was also thinking about, are there any significant differences in the UK nations in relation? Obviously there's all the different examples of co-ops, and they obviously operate across the different nations, but I wondered if there's any differences across nations, and also particularly kind of government and local authority support for co-ops, and if that's a really important issue here.
Do you want to respond on that, Gareth?
Yeah, I'll chip in, and then there are others who also have views, I'm sure, actually. Yeah, I think, I mean, Wales is pretty cohesive, I think, actually. They've got a very sympathetic government. They've got a national cooperative development organisation, and they're very interested in care. Scotland, I think, less so. They're more interested in consortia and employee ownership, and I don't think care is one of their priorities. My sense of England is that it's pretty fragmented, actually. So some local authorities will be keen, and I suppose what is quite encouraging is the whole sort of community wealth building agenda, actually, and where, you know, authorities that are embracing that, there ought to be some synergy and some opportunities for us.
Yeah, I'd echo that. I think that it does feel pretty patchy across England, and very much down to sort of not even necessarily sort of, you know, political makeup of local authorities and the authorities that commission care, but perhaps just down to the sort of preferences of key individuals in those organisations in some contexts. So, certainly our experience here has been very positive, and as Gareth says, you know, the authorities that are engaging in a sort of community wealth building strategy or something like that, and the, you know, significant number of authorities that are engaging in groups like the Cooperative Council's Innovation Network and things like that. Obviously, they're much more well disposed to this sort of model, I think, and we've seen a lot of interest from quite a number of local authorities in what we're doing here. But that, you know, it's a bit of a lottery, I think. So
that was my feeling as well. So actually, yeah, it's just nice to sort of others are obviously on the same page.
I think it's important, the competition element of care is important here, because when we've talked to the local authority, they've tried to adapt to the rules, but the rules are that we are in competition with lots of other care providers, and that therefore any support that they give to us is anti-competitive. The other thing to say is that most local authorities have a rule that you have to get a certain number of hours of care delivered before they will purchase care off you. So we are at the moment only able to work with people who get direct payments or who are self-funded, because we're nowhere near 400 hours. We could get near to 400 hours really quickly if we decided to become big and operate over a lot more of the local authority. And so it mitigates against staying small and the local authorities supporting creative endeavours, because that's seen as anti-competitive.
Interesting, yeah. Good point, Sue. Neil, you got a hand up there.
Hi there, folks. Yeah, good morning. No, it's been really interesting listening to this morning, and I think first off, I think what Lionel was talking about earlier on, it sort of really tells you that when it comes to direct payments or personal care budgets, that you know, it's fine if you have the capacity to do that, but I think the majority of people that find themselves in a situation that needs social care just want to be given the care, basically. I think that's where it comes from. When I did my master's in marketisation of social care, that's when I got particularly, well, I was always interested in cooperatives, but particularly when I did that, and the threats that marketisation have on cooperatives in their own right, which Sue talks about with the competitiveness of it and the way that co-ops are threatened by that, because all of a sudden they're in that sort of environment where they're having to spend money or resources on stuff that they don't want to spend money and resources on. They just want to provide care. Another thought I had in my mind was talking about devolution in Wales. I think with the devolution in Wales in the late 90s, I think it really was a big push for social enterprises, which include cooperatives. In fact, it's enshrined in their laws, in law, that social enterprises, etc., have to be included and have to have a say in how care is delivered in Wales. And that's where I think they've got Wales are ahead of us as far as England is concerned, and why England is so fractured as it is. Cliff talked earlier on. Hi, Cliff. I know a lot of you. he talked about the Hans Kai model, and it was Michelle, isn't it, in Canada that we spoke to, and I had quite a few meetings with Michelle. In a sense, it's quite similar to what you're doing in Colne Valley. I mean, as I said, there's lots of different models out there, and there's not one specific model that fits all. And I think that's something to take into account here. And what I liked about the Hans Kai model was the fact that it gets a lot of people with like-minded, or particularly people that have similar needs, but they become professionals in their own right, and actually they begin to sort of direct how things should happen and how their services develop in their own right. So yeah, there's lots of good stuff going on here. And as I said, with my research at the moment, we've got Kelly here as well, who's my supervisor, and her research, which she's done on micro social enterprises and cooperatives, is really interesting, and I know she's doing lots of work in that at the moment. So I think Kelly's someone that you guys need to be talking to, particularly Veronica and Graham. I think you would actually have quite a lot in common to talk about. But yeah, it's just interesting because the research I've been doing recently, as you know, I'm with my PhD looking at the values and principles of cooperatives and the effects that they have on people that volunteer and work in them, plus the members and people and users, is the fact that I think what Graham and Veronica are doing is spot on, and that's to try and keep it small. It just seems to me that the research that I've done, so I can talk anecdotally because it's not written up yet, is the bigger that cooperatives get, and this is a generalisation, the more fragmented that they become, and the less cooperative that they become, and the less holistic they become. That's just from my own sort of looking at it, etc. And obviously we've got Sue there and her experience in social care, and I'm a qualified district nurse myself. And yeah, I can echo a lot of experiences where you see private companies or private, just taking the money but not really delivering the care. So I'll shut up now because I could waffle on forever. But thank you for giving me a couple of minutes. Thank you. Oh, and also, anyone wants to be involved in sort of my research, I sort of put a link in the chat. So it's all good. Thank you.
That's brilliant. Thank you, Neil. Yeah, I think this is a really interesting point, this thing about size and scale, that I think a lot of people might miss. I think there seems to be this sort of constant drive to achieve scale, and we've deliberately worked against that, I think. And from my point of view, that stems from a conversation that we had right at the beginning of this whole process with Simon Duffy from the Centre for Welfare Reform. I remember we went down to Sheffield to see him, and he talked very effectively about the fact that at local government scale, even at that scale, which is sort of relatively close, I suppose, it's impossible for the people who are commissioning care to get any sort of real sense of the individuals, of the personalities that are involved in terms of their relationship with the people they're trying to provide a service for. Because they're too far removed, they're dealing with too many numbers. So it just becomes numbers on the spreadsheet or whatever, and that has an impact. And it's not because they're sort of heartless people or anything like that. They're extremely, all the people that I've met are in that sort of position are extremely well intentioned and really want to make this thing work, but just the nature of the system that they're working in militates against that, really. So for me, the approach about keeping small and local and a human scale where you can remember people's names and you can see who's who and operate at that level seems to me to be absolutely central to what we're trying to achieve here, and can very quickly get lost. We'll talk in a short while with Adrian about how we see what we do in terms of being able to scale up without having to go through all that horror and losing that humanity. But for me, I think this is absolutely front and center of what we're trying to do. Someone had their hand up a minute ago. Can't remember who it was. Jan, go for it.
Me, Graham. Yeah. Just coming in on that, and also tying into what Sue said, is the blooming elephant in the room, isn't it? Which is the financial aspect of that, because to deliver it in a small scale is just so hard. I mean, in our numbers, when we did our financial planning, it was really looking as if, and it still looks now, as if the only way you can do that is to federate, is to share the back office function.
Which button do I press to send the message?
Oh, which you kind of need to do it properly. But there's a lot of very fine tuning, and we also almost need a sort of a forum like this just to work out how those finances work, I think.
Thank you for that, Jan.
Voice of doom, sorry.
No, you're not. Well, that's the voice of what we've all been facing, and what we sort of need to take deep breaths when we meet, and anytime we have a feedback on how our financials are looking, sort of hoping that we're doing what we can, and that's what it is. And Kelly sort of made a point of, small is absolutely better in social care, and at the same time we have to come up with ways in which we'll be sustainable, because we have to be a business which will work at the end of it. I wonder whether we'll sort of wind down here for a short break, because this feels a really good tying over to the next session, which will happen at past with Adrienne, who's here with us at this point as well. Adrienne, do you want to do like a one-line tagline to get people to come back at past, and then maybe we'll have like a little comfort break and join in the call again at past?
Okay, it's a long tagline, but two things. One is what I've already put together directly picks up and continues on three key themes that have come out in the conversation already. And the other is I have deliberately designed in a very provocative, controversial element to what I'm going to bring that will probably kick off and spill over into Twitter when we get to that bit for some people. Phones at the ready for when we get to that point in my pitch to you all.
Excellent.
Great.
Looking forward to it, Adrian.
Thank you. Thanks for all we've not sort of got to all of the comments in the chat, but that's great. We'll sort of download it, and we'll be feeding back throughout the 3 days as well, and then as a follow-up as well. And if you want to have a little of a break, we'll close the call, I think, so that we can sort of tie it down, finish the recording as well, and then we'll join again at 11:30.